My name is Sarah Eidelson. I'm a chief resident at Ryder Trauma Center, and I'll be presenting on the management of treatment of arrest and of patient. So the objectives of my talk are to discuss both the initial approach of these complex patients as well as the management of GI bleeds, which our case was complicated by. So our patient is an unfortunate 30-year-old male who ran out of gas in his car on the highway in Miami. And when he got out of his car to flag for help, was unfortunately hit at very high speed. He was brought to Ryder by air with a GCS of 3 and vitals en route. He was intubated on arrival. And while he initially had a palpable pulse, this was lost very quickly upon arriving. So we proceeded with a left thoracotomy. His aorta was cross-clamped, massive transfusion was started. He had no pathological findings in the left chest other than contusions, and a right chest was placed that also had minimal sanguineous drainage. Luckily, within roughly 2 minutes of starting cardiac massage and ACLS, we regained a pulse. He had obvious left deformities of his right lower extremity and his left upper extremity. He had an open pelvis, several deep lacerations that were bleeding profusely on his scalp and arm, which I'll show pictures of later. I don't know. Let me start. I put these in.
Did his level of consciousness improve?
No, he was always a GCS of 3.
I see. Okay.
You went a little too fast. Could you slow down a little and tell us one more time what you did?
Sure. So he lost pulses pretty much immediately upon getting to the resus bay, and we did a thoracotomy. We cross-clamped him and we got him back. And the injuries we knew up until this point were this bad deformity of his right lower extremity, his left upper extremity, what looked to be an open pelvis. And then he had a really bad scalp, face, and hand lacerations that were bleeding profusely.
Yeah, so Sarah, this is a blunt trauma. So I would ask the people around the room also first, if you have a cardiac arrest or blunt trauma, everybody just do a ER thoracotomy or not? Because some places do, some places don't do. So I would start with that, and then ask what to do at this point, right? But so far, great management. So Gary, let's go around.
Yes, sir. Let's go to Las Vegas to Colonel O'Connor.
Yeah, the military CPGs for that we operate under, you would definitely do a thoracotomy for this person because even though it was a blunt trauma, they lost vitals within the hospital. So that's an absolute indication to do left thoracotomy, state of thoracotomy. That's what I got.
Thank you, sir. Sao Paulo, Dr. Calais, your comments, please.
Yes, I agree with the comments. Patients who arrive with vital signs, a lot of vital signs during the transportation on the hospital in a blunt trauma. Initially, I tried to go to a thoracotomy, a emergency room thoracotomy, and clamp the aorta and open and do other maneuvers in the chest. But it's a very difficult decision, but I think it's very important that I can go to left thoracotomy and start reanimation situation.
Thank you, Dr. Calais. Can we go to Boston, Dr. Mahoney? Check your mute button, please.
There we go. I agree. And as far to answer how we do it, is somewhat nuanced. If a patient came in with vital signs and lost his pulse in the bay, we all of us would do the thoracotomy there. As I remember previous discussions, I think the survival of a blunt traumatic arrest is, it's abysmal. I think the previous presentations at this forum, it was less than 1.6%. I don't know if that's better. We all feel though, if a patient shows up with a pulse, it's worth the effort to try to salvage if we can't rescue that patient. My own practice, with BMS, if it's in the field, they lost the pulse in the field and they've been doing CPR entirely en route, then it is more nuanced. Some may, if it's been a very short period of time, but if there's been any duration at that point, we would not do it in the field. In this case, though, we would proceed.
Thank you, Dr. Mahoney. Let's go to Atlanta. Dr. Frisbee, your comments, sir.
Yeah, I think that's right. The standard by which you open these patients has been changing over especially towards trauma patients. I mean, you can consider this blunt trauma if you want to. The only reason you're not seeing any blood is the skin's still intact. He's bleeding everywhere. You just can't see it yet. So I think the correct procedure is what you did. I would have done it too. That's all I've got.
Thank you, Dr. Frisbee. Trinidad, Dr. Ali. Check your mute button, sir. Your mute button, Dr. Ali. We cannot hear you. I'm sorry, Dr. Ali. Lower left-hand corner of your Zoom screen.
I'll move it.
Okay, we have you now. Thank you.
All right. So I say this is not just a normal blunt trauma. The situations are different, and it's a young person. We don't know how long he was without circulation. So I agree 100% that we should give it a try. And he may have lost a lot of blood in spite of not having seen any in the chest, because he has peripheral, he's got an open pelvis, which may be full of blood. He may have lost a lot of blood before. And so I think clamping the aorta when you got in there to see if you can get perfusion to his head is also a good technique till you decide what else is going on in this patient. I agree with doing the thoracotomy and clamping the aorta.
Thank you, Dr. Ali. Can we go to Sao Paulo, Dr. Calais?
I already talked that I agree with that, make a emergency thoracotomy in this situation.
Thank you, sir. Iraq, Dr. Untrat?
Yes, I agree with all of the comments. The patient had a pulse coming in. He lost it right in the trauma bay, and obviously was from blood loss into the abdomen. And so I think this is absolutely the right thing to do.
Thank you, sir. Portland, Dr. Kasim, your comments, please.
I think the dictum is that if you see this patient in the trauma bay going into arrest, you're doing a thoracotomy for two reasons. One, to cross-clamp the aorta and the circulation to his brain to keep it alive and viable, and also to relieve pericardial tamponade if there was any. And so I witnessed cardiac arrest in the trauma bay. It's an absolute indication for thoracotomy, but in the book it says that within 5 minutes of arriving in the trauma bay, the salvage is dismal, like Dr. Mahoney said. It is less than 1.5%.
Thank you, Dr. Kasim. Dr. Hoyman, join us a couple minutes later. Are you prepared to comment at this time, or should we wait the next round?
No, I have Dr. Mahoney is representing us today.
Okay, excellent. All right, thank you, sir. Dr. Ratan wishes to comment.
Yeah, sorry, I just had a question. I'm not saying that I would do this, but I was just wondering if anyone would consider bilateral chest tubes and a zone 1 Reboa with closed chest compressions. I don't know that any of us at Ryder would do that, but I was just sort of wanted to get a sense of what the international opinion on that is.
Sorry, Dr. Ratan, was that a question to the group, sir?
Yeah, question to the group.
Okay, anyone have a comment in that regard?
I think the answer is going to be no, because it takes too long time to get all those accomplished.
It's probably quicker to open the belly to see if there's any bleeding in there, and if there isn't, just put a pack and get going, because time is of the essence here. And I wouldn't go with the maneuver of cannulating the aorta and so on.
May I speak something? When you have a blunt trauma, sometimes you have injuries in the chest. One of the injuries that you may have is a pericardial hole, rupture of the pericardium, herniation of the heart through the pericardial hole. And if you put any, in this moment, you put any Reboa or others, can not find it, and the compression is not very good in the situations. I have 3 or 4 cases that I have a pericardial hernia, do a pericardial rupture in the blunt trauma. I believe there is other issues, but one is that one.
Thank you for the comments. Let's see, Dr. Marttos, are you still with us, sir? Okay, no. Do we have any other comments before we return to Dr. Eidelson? Okay, back to you, Dr. Eidelson.
What? Yeah, Gary, I have one quick thing to say.
I'm sorry. Go ahead, Dr. Lieberman. Sorry.
No
about
worries.
that.
As I said, this was my patient. I'm really probably overly aggressive with ED thoracotomies. I pretty much do them on everyone. But I will admit, when this patient came in, I hesitated for about 2 seconds because you didn't see them or the pictures yet. But I mean, this guy was just broken from head to toe. I mean, shattered everywhere. He just did not look like he was going to survive. But because he was young, I said, okay, let's just go ahead and do it. And I just wanted to know if anyone in the group would have, based on just his physical appearance and of the fact that, let's say he was 65 or 70, would you have gone ahead and done a thoracotomy? I think based on what I saw in the trauma bay, if he was double the age, I probably would have just pronounced him.
Any comments in that regard?
Age is just a number, and I think you should give the benefit of doubt, irrespective of what your eyes are telling you that he has multiple injuries. I think you should do what is right.
Okay. Thank you for your comment, Dr. Okay, let's return to Dr. Eidelson if we don't have any other comment. Go ahead, ma'am.
Okay. So we took him to the ER, we removed the cross clamp, performed an exploratory laparoscopy. We found a non-expanding zone 3 hematoma. We found a very large extraperitoneal rectal injury that communicated with this deep boring laceration on the left. I'll show pictures of shortly. He also had a serosal tear in the midjejunum, and we unfortunately caused an iatrogenic defect in the mesentery that was repaired, but in close proximity to the jejunal tear, which will come into play later. We called OMFS and ortho hand into the room to help us with the bleeding from the face and the hand while we explored the abdomen. This was a post-op x-ray just to show you how bad his open book pelvis was. This was the large groin laceration that communicated with his rectal injury, which was deep down to his pelvic bone, which luckily missed the femoral vessels, and he had palpable pulses on the left lower extremity. His rectal injury that communicated with that laceration. And then this shows the degloving injury to his ear. I'm sorry we don't have more pictures of all the lacerations he suffered to the face and extremities, but these were all considerable in size and a big part of his blood loss that came from his injury. So we can talk about the next steps and specifically the immediate management of his extraperitoneal rectal injury.
Trinidad, Dr. Ali, your comments, sir? Go ahead, Dr. Ali, if you like. I'm sorry, sir. Check your mute button again. Lower left-hand corner of your Zoom screen. Yeah, thank you.
I lost you guys there. I'm sorry.
Okay, no problem. Go ahead, please. Would you like to comment, sir, or would you like me to catch on the next round?
Just go ahead, because I missed quite a bit of the presentation. I was disconnected.
Okay, very good. Let's go to Portland. Dr. Kassim?
Well, I think you need to establish damage control here. You've lost a lot of blood, so you're not going to be doing anything heroic, but you need to stop the bleed wherever it's bleeding from. The ear is the last thing that you will deal with. Just wash it and pack it, and stop the bleed in the abdomen. And if there are any tears in the jejunum, I think you'll just staple it in continuity and leave it alone. And then you need to come down to the pelvic area. If there is anything bleeding there, pack it, and again do a good washout and divert in the left lower quadrant somewhere, and get the patient to the ICU to get him warmed up at least, because you would have, by now, you would have given him a substantial amount of blood, and he probably will be cold, coagulopathic, and acidotic. So you need to you need to take care of the triad and avoid any further insult to injury and get the patient to the ICU for further resuscitation. Thank you.
Thank you, Dr. Kasim. Let's go to Iraq. Dr. Undrat.
Yes, I generally agree with all of Dr. Kasim's comments. So it looks like the bleeding is largely stopped, or I guess there was still bleeding from the scalp and some of the orthopedic injuries. So, you know, those need to be stopped. And then in the abdomen, it looks like there's really no active bleeding. There's a non-expanding zone 3 hematoma, and the serosal tear looks like it can be repaired rather quickly. As far as the rectal injury, it's hard to tell what access you have, whether it's through that groin wound. Sounds like it would be through the groin wound. It'd be difficult to access through the large hematoma in zone 1. So I think if it were easily accessible that way, and I can't see it in that photo, but okay, I see. So that's your finger, your index finger coming through through the rectum, coming through the wound. So in that case, I would repair that primarily, and then he will need diversion at some point. If there's no soilage, I guess that could be deferred if you want to get out of the operating room. Otherwise, I would try to do probably a sigmoid loop colostomy, close that injury, and then you need to establish drainage, which early on you could just leave that wound packed open, and then when you come back at a later time, then you can establish more definitive drainage to breathe the wound and probably in this case treat it open. So in this case, to answer your question about the rectal wound, I would repair it through that wound that you have, and probably pack that wound open and let that be the early drainage, plus or minus a diverting sigmoid colostomy at this stage, and then ask the orthopedist about potentially putting an external fixator to close that open book fracture of the pelvis.
Thank you, sir. Atlanta, Dr. Frisbee, your comments, please.
Well, I think Kasim hit it, except I agree with him, except for one thing. I don't think I would divert this patient. I think I'd pack him and I would close off any of the mesentery or any of the jejunum that might be of a problem. I think I'd put an umbilical tape around the distal portion of the sigmoid and pack those wounds open, especially the rectal wound. Just pack it open and take him as fast as you can back to the ICU. This guy's going to be cold. He's never going to stop oozing until you start to resuscitate him there. So the quicker you can take care of the situation where he's not bleeding and get him back to the ICU, the higher the incidence of recovery you'll have. Now, some of these things that are mentioned are very well, except for the fact that the orthopedic case, I think that's something for later. I think the ear's something for later. Your plastic people have already whip stitched that scalp laceration, I'm sure. And as long as you've got him not actively bleeding, I'd take him right back to the ICU and come back another day. Give him a chance to resuscitate and then come back and address these things. But I don't think I would divert him at this time. That's all I got.
Thank you, Dr. Frisbee. Sao Paulo, Dr. Clay.
Okay. At the moment, I agree with the comments. In these situations, I believe that these patients need to be controlled the hemorrhage only. Damage or control the hemorrhage. The stop blending, fix the pelvis, and damage control in all situations. The rectal injuries in these situations, I know that as patients, the good treatment is suture and make devisculation and clear the rectal and don't close the wound at the first time. But in this situation, the patient is not stable. I don't do anything in the rectal wound. In this moment, I think it's control the hemorrhage, the devisculation, and the clear the column And I do in the next time on the second view of the patient. In this situation, the patient may become more stable. In this, and then I go to reopen the patient, put the colostomy and clear the colon, distal colon, and suture the rectal injuries and try to make to repair these injuries at this moment. And the moment that in this moment, at the acute moment is the injury, I don't have do this in the moment.
Thank you, sir. I'm sorry.
It might be worth mentioning that I should have said earlier is that while he was bleeding a lot at the beginning of the case, mostly from these lacerations, the long bone fractures, we stopped MTP pretty early on once we were in the belly. He had been stable in the operating room for after we got control of the lacerations, like even the pelvis, even though the binder wasn't on at this point, he had been stable after about an hour and a half in the case. So he gotten a lot of blood initially, but then he had stabilized during our X-lap. I don't know if that would change, your decision tree at all.
May I have, in this moment, it may be, although the patient may be, during the surgery, may be stabilized, but this patient is not stabilized, it's acidotic, hypotension. In this moment, I don't do anything in the perineal injury. I have one case or two cases here that we have decided to make the colostomy, the vertical lesions, and the second surgery, and not the first surgery. And it's very interesting because the contaminations for this period is very small, and you can do is more safety for the patients when he's completely stable, hemodynamical, and acidotic, and coagulopathic, and normothermic. So in these situations, I believe it's more safe for the patients to treat in 2 steps, it's not in only 1 step.
Thank you, Dr. Khalid. Dr. Mahoney?
Can I ask a question?
Yes, sir. Ready for your comments, please.
So my comments, I agree with everything done. In my judgment, this is a damage control, open up. The presenter, you mentioned that you'd stopped a massive transfusion protocol. And it seems like based on clinical, the patient looks like he's clotting. Was it based on that, the clinical judgment between the operative team and anesthesia, or was it based on TEG, or you said that you had stopped the NTP? That's sometimes difficult to do. Once that gets started, anesthesia just keeps pushing blood and things like that. What was that based on?
Yeah, we were in close contact with our anesthesia colleagues. They're good about keeping us updated with sending tags and recesses throughout the case. So it was both his crit and how he was doing clinically, and the fact that all these lacerations at this point had been controlled, and we didn't really see anything other than this non-expanding zone 3 hematoma in his belly, and he had 2 chest tubes that weren't putting out anything. And we knew that the pelvic hematoma wasn't expanding, that all these kind of played in our decision.
And did ortho come in and put an X-fix on this?
On the pelvis, they put a binder on him. The X-fix came later.
Okay. Thank you.
Thank you, Dr. Mahoney. Let's go to Vegas. Colonel O'Connell.
I think if I were taking care of this patient, I would make sure they had a pelvic binder on. I know it looks like from the pictures that might interfere with exploring this really severe perineal injury. But that would be one approach. Something that hasn't been mentioned is to do a combined series of incisions on the abdomen that allows you to do an exploration of the abdomen above the umbilicus, but possibly doing a preperitoneal packing. That's another option. I would say for his contamination of his open pelvic fracture, that's got a mortality of about 50%. So you could have delayed mortality from there. I think obviously doing a colostomy at the time of the first surgery would be the wrong decision, but perhaps you could just staple off the colon, at least temporarily, to put the patient in the ICU. And then I would be concerned, obviously all the bleeding stops when the patient loses pulses because there's no blood pressure. I would be concerned that the patient has expansion of his hematoma. So if he's stable enough, could he be sent for a CT scan of the abdomen, or to angio to possibly embolize any vessels. I'd also say that keeping a balanced resuscitation, administering TXA, and keeping the patient warm would all be very important in this patient.
Thank you for your comments, Colonel. I just noticed Dr. Calderon is here. Sir, would you like to comment, or are you going to observe today?
I was only going to observe. Something small to say. If you were unable to place a urinary catheter in this patient, the only formal procedure I would do is a cystostomy tube placement. Otherwise, I would only pack the wounds and leave the rectal repair for later, as you already said. Thank you.
Thank you, sir. Any other comments before we return to Dr. Eidelson?
Yes, if you allow me, Dr. Ruiz.
Sorry,
here.
Dr. Ruiz. Go ahead, please.
No, first of all, I'm very surprised that this patient is still alive. Congratulations to the team. At this point, it's incredible to keep the patient alive. These are very frustrating. Bringing the patient back from death is not that difficult, and most of them will come back, but keeping them alive is where the problem is. So working with anesthesia, who tends to over-transfuse the patients and put them into right-sided heart failure and congestive heart failure, it's a thing that you have to do from the beginning. I usually fail at this stage because the patients bleed to death. All the new fronts that you open with the thoracotomy start oozing, and the patients just go into cardiac arrest, hyperkalemia, and acidosis that cannot be recovered. So I'm interested in hearing what happened within the next 2 or 3 hours of this moment, and how did the patient do at this point. One of the things that I always tell my fellows and my residents is to watch closely for the development of refractory acidosis and coagulopathy, because once they're in that setting, it's very, very difficult to get them back. So congrats up to this point to them to keep this guy alive, and I'm interested in hearing what happens from here on. And to echo Rich's comment, maybe in the future we're going to be doing more Riboa in these patients, because in my patients at least, one of the reasons they die is from exsanguination from the chest. It's incredible, but they exsanguinate from the chest once the hemorrhage is controlling the abdomen. So that's it.
Thank you very much, Dr. Ruiz. Any other comments before we return to the presentation?
Yeah, Gary, can I?
Yes, sir, please. By all means, go ahead.
Yeah, so again, let me try to just paint a little bit of a better picture of what's going on. So, this guy comes in, he's basically dead. He gets an ED thoracotomy. We get return of spontaneous circulation, and we go straight to the OR. There's no imaging, there's no nothing done. The only thing we know is that he came in arrested, we got him back. He's got obviously open fractures, lacerations, and a big left inguinal injury. At this time, we don't even know that there's a rectal injury whatsoever. We get him into the operating room, and like all of you, we're thinking the money's going to be in the abdomen. We lap him, and he has a pristine abdomen. He has no intraperitoneal injuries at all. He has a small zone 3 retroperitoneal hematoma that was stable, wasn't expanding, and no other injuries. While we're doing this, he is exsanguinating from his ear, his scalp, and all the digital arteries of his left hand were like pulsatile bleeding, and his open fracture of his lower extremity. We're lucky enough that we work in a level 1 trauma center with a lot of support. While we were finishing up the X-lap, we had the oral surgery service come in. I didn't even realize it. They sewed up his scalp lac and took care of his ear. That stopped the major source of bleeding. Ortho was dealing with the hand and all the pulsatile bleeding from his hand. That took care of another big source of bleeding. By the time we finished the X-lap, all that was controlled. His vital signs were completely normal. His ABG had become like a normal, pristine ABG, if I remember correctly. He wasn't requiring any more blood. He wasn't hypothermic. And he literally went from someone who was dead with all the physiology that's associated with that to pretty much a normal physiology, not acidotic, not tachycardic, not hypotensive, not requiring any blood, making urine. And then we diverted our attention to the inguinal region, did a rectal exam, and that's when we saw, obviously, that basically his whole rectum was gone. There was nothing, I know someone mentioned, to try to primary repair it. There's nothing to repair. It was just gone. It was obliterated. There was just nothing there but a big hole, a big space. So as Sarah will tell you, the next sequence of events, but that's essentially it. To my surprise, the biggest thing that surprised me about this case was that he had 0 abdominal intraperitoneal injuries whatsoever. And it looked like all his bleeding was probably originally from that groin wound, but more importantly, it was from the ear, the scalp, the hand, and the right lower extremity. Those were just exsanguinating profusely while we were, in there trying to do our X-lap. And like I said, we had other teams come in to take care of all of that. But once that was taken care of, he pretty much normalized and was a quote unquote stable patient at that time.
Thank you very much for your comments there, Dr. Lieberman. Anything else before we return to our presenter? Okay, Dr. Eidelson, back to you, please.
We performed a sigmoid loop colostomy and repaired that serosal tear on the jejunum. OMFS and ortho-hand were helping us simultaneously, as Dr. Lieberman mentioned. We washed out his groin, we closed his chest after leaving 2 chest tubes. We performed a temporary abdominal closure to the abdomen, in part because we wanted to get a good look in that area in the small bowel and the mesentery that had been injured. And the next day or two, a pelvic binder had been placed. We've done roughly 3 liters of blood throughout the case, but this has all subsided about an hour into the case once those last closed. Like he said, the acidosis had normalized. We weren't transfusing him as crits. So post-operatively, we did send him for a full pan scan. In addition to the several long bone and open book fractures that he had in the right lower extremity and left upper extremity, he had a severe TBI with sizable intraparenchymal and subarachnoid hemorrhages. He had a C4 through C6 fractures with only single vessel runoff to the right foot, and he had bad bilateral pulmonary contusion. Neurosurgery placed an EVD, and the pulse that he initially had on his right lower extremity was lost, and he went emergently to the OR with vascular for a right above the knee pop to posterior tibial bypass by our vascular colleagues, and an X-fix to the right lower extremity was placed. Later that day, the pulse was again lost, and he went back with vascular for thrombectomy and revision. Post-operative day 2, his condition worsened with increasing pressure requirement and coagulopathy. His ICPs were up to 30. A pelvic X-fix was placed, and he was taken back to explore the abdomen. Unfortunately, that area of the jejunum we were concerned about now showed a 3-centimeter non-viable segment.
Let's go to Trinidad. Dr. Ali. Check your mute button, sir. Dr. Ali, you're still muted. Lower left corner of your Zoom screen. Okay. Yes, sir. Go ahead, please.
So the abdomen, apparently it was just within the abdomen, there was just one injury, and that was devitalization of the jejunum, right? Nothing else. And the rectum was completely evulsed.
Yeah, I mean, we had done the sigmoid colostomy, and the
Yes.
was stapled off, and we had been packing that groin, so we just had
the bleeding was controlled.
Yeah,
Yeah.
and I was clinically not doing well at this point 2 days later.
I see. Well, I don't have anything further to add at this moment.
All right. Thank you, Dr. Ali. Let's go to Atlanta. Dr. Frisbee.
Well, he's sliding away from you. So get in there and take that sigmoid, that jejunal segment out of there before it becomes completely necrotic. But other than that, that's it. I'm curious, how many units of blood did this patient get?
On the first operation, he got about 15, I believe.
15, and he's hypothermic. I mean, he's normothermic.
Mm-hmm. And those were all within the first hour of him being in there between recess and the OR. And then for the last, I'd say, hour and a half, requiring no transfusions. But now 2 days later, where he had initially improved, he was okay for scanner, and then he started to decompensate the next day. But I guess the question is whether or not anyone would, obviously this segment needed to come out, but whether anyone, doing an anastomosis at this time. or leaving him in discontinuity.
I don't think that's important right now. We can come back to him. Come back to his jejunum. Just get that necrotic portion out of there. That's all I've got.
Okay, thank you, Dr. Frisbee. Let's go to Vegas. Colonel O'Connell, your comments, sir.
I would resect that segment of bowel. I don't think I would reanastomose him if he was on pressors because of concern out of a leak. I would probably also check the status of the rectum and see if he had a pelvic source of sepsis.
Thank you, sir. Boston, Dr. Mahoney, your comments, sir?
As we all know, this is really complicated. So if I go by neurologically, that's been addressed. Neurosurgery has the ICD, and it sounds like his cerebral perfusion pressure has been okay. We don't think there's any new, like a vascular injury to the brain or anything like that. Regarding his abdomen, I agree. Going back in there, you go in. As I believe you stated, he's coagulopathic now and escalating pressure. So at this point, I would just resect that segment, leave him in discontinuity. Planning on taking him back within the next 24 hours for another look, but I agree, just resect that segment and get out. Now, in the interim, you had said that initially you got a CT scan of the pelvis, presuming that you assessed the pelvic vessels. He doesn't have any issues there. I know there was a vascular revascularization. Now, was there a repair of the rectum between day 0 and day 2? At least because that's, as the Lieutenant Colonel had mentioned, there's a chance of ongoing sepsis from this rectal wound. Invariably, there's some stool burden still within the rectal vault that will be an ongoing source of contamination. And so was there a additional look post-injury day 1 to try to, put together what was possible, and or is that an ongoing source of sepsis?
So every time we took him to the OR and both bedside, we would irrigate the wound through the inguinal wound copiously. And as far as trying to repair any tissue, like Dr. Lieberman said, there's really nothing identifiable. It was completely torn to pieces. So we just irrigated and packed it twice a day. Took a good look at it every time we could when we took him to the OR. It was pretty much every other day at this point. So that wasn't, we don't really think that was the source of sepsis at this point.
No, so then, yes, agree. We take him back, resect and sort of wash him out and sort of correct his coagulopathy and try to adjust his press requirement. Was his white count also going up?
White count was increasing at this point.
All right.
Thank you, Dr. Mahoney. Sao Paulo, Dr. Calais, your comments, please.
Yes, at this moment I agree with the comments, and for the moment I believe that we have to resection of the necrotic bowel, and don't make anastomosis. We go to a second look, and usually in the rectal wound or the perineal wound, washing the perineum and see if there is no contaminations or septic for maybe treat at this moment. Only this.
Thank you, Dr. Calais. All right, Dr. Untrat, your comments, please.
Yes, I agree with keeping the laparotomy brief, resect the non-viable segment and staple across the ends. And as far as the pressure requirement, it suggests he has a source of sepsis. So if it's not the perineal wound, it could be one of the open fractures or perhaps pneumonia. So I would keep the operation brief and take him back to the ICU, look for the source of sepsis and then treat that.
Thank you, Dr. Untrat. Portland, Dr. Kasim, your comments, please.
Sometimes when you see serosal injury like this in the first operation and the patient is receiving 15 units of blood, it always bothers me at that time. And that's the reason why I recommended that I would have resected that area and left the jejunum in continuity. And now you're facing sepsis, so you need to find out where the sepsis is coming from. And once again, I would have done a colostomy. Don't want to upset my colonel there, because the stool load is quite significant in this particular patient, and he will continue to soil the perineal area, and you say the rectum is non-existent, and obviously he's going to be contaminated in that area as well. So you're dealing with sepsis. And as you know, patient with hypotension and sepsis, the mortality is over 50%. So what I would do is I probably will resect the jejunum and wash out and look for areas where sepsis may be hiding, and then thorough irrigation, and then make sure the defunctionalized part of the sigmoid colon is devoid of any stool that could contaminate the perineum. And I would have created the colostomy way ahead. So those are the steps I have.
Thank you, Doctor.
I don't think this is a long bone infection. It's too soon to manifest itself at this moment.
Okay, thank you, Dr. Kasim. Can we go to Ryder? Dr. Ruiz, you have a comment, sir? And also back to Ryder, Dr. Lieberman.
Yeah. So yeah, just again, we during that first operation, on day 0, time 1 hour, as soon as we saw that devastating rectal injury, we did a diverting loop sigmoid ostomy on him. And it was during the creation of our loop sigmoid ostomy that we made an iatrogenic injury in the mesentery of the jejunum. Accidentally, an instrument got closed on the mesentery and poked a hole right through it. So at that time, it didn't look very significant. We repaired it, knowing full well that it could lead to an area of ischemia, but we knew we were leaving his abdomen open, and we knew we were going to go back. So I didn't want to give him an ostomy and a bowel resection all at the same time, knowing that if it did become ischemic, it probably would take a few hours or a day, and we would catch it the next day on our return to the operating room. So again, the injury was 100% our creation, our own iatrogenic injury. Like I said, it was just a clamp was accidentally closed and pierced right through the mesentery. It was maybe about a ½ centimeter defect in the mesentery. Very, very small segment.
Thank you, Dr. Lieberman. We'll stay with Ryder. Dr. Marttos, your comment, sir.
I just watched. I know the case. Let's keep going.
Okay, very good. Any other comments before we return to Dr. Eidelson? Okay, back to you, ma'am.
So like pretty much everyone said unanimously, we accepted that segment, and given his clinical condition, we left him in discontinuity. The only other thing that we did we placed direct peritoneal resuscitation catheters, which, if anyone's unfamiliar with this, it's catheters left in the abdomen to infuse hypertonic solution, which has been shown to aid in tissue perfusion and decrease bowel edema, thus accelerating abdominal closure and decreasing postoperative complications from damage control laparotomies. So we did that. On post-op day 3, his bypass went down again, and he had worsening ischemia to that right lower extremity. So we proceeded with a right lower extremity through the knee amputation. We also performed another abdominal washout at that time, performed staple anastomosis of the area left in discontinuity. And since we couldn't chemically anticoagulate him secondary to his TBI, and we didn't want to send him across the hospital to IR, we placed an Angel catheter, which is a deployable and retrievable IVC filter that's attached to a triple lumen catheter that we place in the OR. We did another temporary abdominal closure with plans to take him back in 24 to 48 hours. We did this on day 5. He went to the OR, the anastomosis was intact and patent, and we closed his abdomen definitively. Over the next week, he was weaned off pressors. His T-billy and LFTs continued to rise. We attributed this to shock liver, but had hepatology on board in evaluating him. His EBD was removed, his ICPs downtrended, and repeat imaging showed stable findings of his TBI. He was taken back to the OR on post-op day 8 for revision of his guillotine to above the knee. On post-op day 10, he became febrile and hypotensive with worsening AKI. His wounds looked increasingly worse, both the pelvis, the left laceration and the right lower extremity, and he was taken back to the OR emergently for debridement. He also became C. diff positive at this point and had a positive BAL. On post-op day 5, he had an acute drop in his hemoglobin from 5 to 5.6 from 7.7, was transfused several units and had an inappropriate response. The following day, his hemoglobin continued to be low. He was transfused again, started on pressors, started to have a large volume of melanoma from his colostomy at this point. He was also started on dialysis. GI was consulted. They started with an upper endoscopy, and they found a very large ulcer at the GE junction that they thought might have been the culprit, although it wasn't actively bleeding. He then bled thereafter, so the decision was made to send him to the CTA, which identified an active bleed and looked like it was coming from our site. It was coming from our anastomosis, although they couldn't be sure on the scan. He continued to bleed, so GI did a colonoscopy through our colostomy and got to about 20 centimeters proximal to the TI, but couldn't identify a source. So at this point, they had a patient requiring long-term resuscitation who is now 2 weeks post-op from our abdominal surgeries, with our likely source being our anastomosis that was unable to be reached endoscopically.
And that's important. I was the ICU at this point, and then the patient started had this massive GI bleeding, dropping hematocrit. So then I have a surgical decision to do here, or what to do, how to approach this bleeding. So let's listen to everybody in the room. So what to do now?
Okay, let's go to Dr. Clay in Sao Paulo. Comment, sir?
This is a very difficult case to decide because you don't know the surrounds of the blending, you know that. So you can do, in these situations, I have to, if I don't know, I can open the patient, call the endoscopy, and make an incision of the ball, and put the endoscopy to try to find where is the blending coming. If it's possible, in the situation, the patient is possible, I go to put the patients in the, make a angiographic of the abdominal vessels and try to find if there is vessels with blending and try to fix it by endovascular procedure. That's the way that I have, I can do. So in this situation, sometimes I make, it's very difficult to control the hemorrhage in this situation. But I believe that the tools that I have, that I can use one of them where I was working and I have these tools to use.
Thank you, Dr. Calais. Boston, Dr. Mahoney, your comments, please.
And so, as we know, with a massive GI bleed, you can have blood coming up, vomiting, hematemesis, as well as same time massive lower GI bleed. So going in, we need a target. And so it sounds like you did due diligence to find that. The endoscopy didn't show active bleeding. With the newer generation CT scan, if the patient's stable enough, a CTA of the abdomen is a great way to localize it. If the patient's less stable, what I've done in the past couple of days is gone to angio in IR to try to localize it just by selecting vessel to see if they can identify it, if you have some type of hybrid suite, you can then open up the abdomen as well. So it sounds like you found a target and then you're just addressing that. So if your target is right at the small bowel anastomosis with ongoing clinically significant bleeding, then redoing your anastomosis, repeat bowel resection seems appropriate. Thank you.
Thank you, Dr. Mahoney. Trinidad, Dr. Ali, your comments, please.
Yeah, well, it seems like the only source that we have found so far that we can define is the anastomosis in the jejunum. And that, if it's still bleeding, I would think if you take the anastomosis down and have a look in to see if there's active bleeding, to do that. Otherwise, I will clamp both ends and wait for another day to try and do something more definitive at this stage. And the angio, he did have an angio, did he say, or no?
Not yet, no.
Oh, I see. Because I have that as another option once he's stable enough to go to the angio suite.
Thank you, Dr. Ali. Portland, Dr. Kasim, your comments, please.
I don't think you will find the bleeding if you wait for the patient to be stable. I think you need to strike it. You need to strike the iron when it is hot, when he's bleeding, so that you will get the answer that you're looking for. And I think if a patient is bleeding 0.6 ml or 1.6 ml, something like that per hour, and the angio people will be able to see it. So I would probably resort to my friends in the angio department to localize the angio bleeding site for me, rather than relying on the endoscopist at this moment. It is very frustrating that when you have a patient, you have come this far and he doesn't want to give you a win, and you're losing because he's bleeding and you don't know where the bleeding is coming from. It's frustrating and annoying as well. So you have to do your best. Thanks.
Thank you, Dr. Kasim. Let's go to Colonel O'Connell in Vegas. Your comment, sir.
It's a tough case. I think the pitfall would be misidentifying, identifying an incorrect location of the bleeding. You think it's one location, you don't. The small intestine is notorious for tricking people. I am curious about the determination that's coming from the anastomosis. I wonder if that's because there are radiopaque clips in place from a staple line that help them come to that determination. I have heard of ulcers and bleeding coming from anastomoses. I think I remember 1 or 2 cases from residency. I saw Dr. Sleeman take a patient back. But given everything that you said, I would probably take the patient to the operating room and redo the anastomosis. And I would be, if the patient did go to angio, I would be concerned if they decided to go ahead and embolize any of the small bowel. I don't know if it would tolerate an embolization. I've never seen that or contemplated it.
Thank you for your comments, sir. Atlanta, Dr. Frisbee.
Well, I got a couple of things. Number one, I think I do the angio before I decided to resect or reanastomose the jejunum. You don't want to go in there anymore than you have to. And if you can get both answers at the same time, then that's what you need to do. Doing the anastomosis again, and then taking the patient back to the angio and doing something else again, just lengthens out the time. And the other thing I've got is my friend Kasim. You can't take these things personal, but I can understand how you might. You're working hard, and they'll give you a win. Just keep at it. But those are the only comments I've got. Thank you.
Thank you for your comments, Dr. Frisbee. Iraq, Dr. Untracht, your comments, sir.
Yes, so obviously this patient had a lot of bleeding. I'm a little skeptical that how many days after the anastomosis, 3, 4, 5 days, I lost count, but it wasn't right away, that he's pouring out that much blood from a stapled anastomosis. I suppose it's possible, but I'd be a little bit skeptical. The other possibility would be hemorrhagic gastritis, notwithstanding the upper endoscopy that saw a large ulcer and apparently wasn't bleeding at the time, but that's another possibility in a patient like this. So I think it's reasonable if you have if the patient's stable enough, do the angio, see if you can locate the source. If you can't locate the source, then I agree with Dr. O'Connell. You pretty much have to take the patient back to the operating room, and I think there's a reasonable chance you'll be able to figure it out. If it is hemorrhagic gastritis, you can see this, the stomach will just look dusky and not healthy, and usually it's from diffuse ischemia that the mucosa sloughs and causes all that bleeding. So that might be obvious, or it might be obvious if there's all the blood coming from the anastomosis on distally. So it's so first the angio if you can do it. If not, then back to the OR to figure it out there.
Thank you very much, sir. Dr. Lieberman, you have a comment, sir?
Yeah, just really quickly, I guess like everyone else is saying, there's 2 options here, right? You go back into a hostile abdomen, you take down a bleeding anastomotic site to redo another anastomotic procedure. And yes, it was about 14 days or so after the initial anastomosis. So I too was really perplexed at why this would bleed so far out from it. The other side of the coin is taken to interventional radiology, angiography. If they find the bleed, they can embolize it. And if you get lucky, it stops the bleeding. It doesn't cause any ischemia. And you just saved yourself a lot of heartache and trouble and potential more complications by going into an abdomen. So Sarah will tell you sort of which path we took, but I mean, those were pretty much the only two options. You go back in, take down anastomosis and a hostile abdomen that was bleeding for reasons we don't really know. And then to do another anastomosis was kind of not sitting too well with me. And then the flip side, like I said, was going to IR, embolizing it and possibly causing some ischemia. And then I guess you'd be back in the same position, having to go back into the abdomen. But in my mind, that was kind of at least giving us an option where we could potentially not have to go back into the abdomen.
Thank you, Dr. Lieberman. Any other comments before we return to the presenter? Okay, back to you, Dr. Eidelson.
So, and I guess anyone can chime in if they have this issue with IR in there. We consulted them, but their concern was, as Dr. Lieberman mentioned, that embolizing that area would cause ischemia, necrosis, and anastomotic breakdown, and they were very resistant to doing this. But eventually, after a long discussion with their team, we decided that the risk of an operation 2 weeks post-op and his clinical condition outweighed the risk of embolization, and IR did perform the embolization of the distal branches of the SMA in the operating room with us on standby in case they didn't see anything active and he was still doing well, that we were prepared to proceed with surgery. So luckily he did well post-operatively and remained stable on pressors. His bleeding had stopped and his lactic acid is normalized. Since that time, he has had no further issues with GI bleeding. Clinically, he's, however, the most critical ongoing issue with him at this point is that repeat imaging of his brain have failed to show an improvement. He's also since gone for an MRI with C-spine injuries with neurosurgery believe, or he has a high likelihood of unfortunately being quadriplegic long term. So that pretty much brings us up to the day with him, and he's going to get our trauma ICU. So I'll take any final questions or comments about the case.
So final comments. Let's start with Dr. Ontrak in Iraq.
Well, you know, difficult case, and you know, the patient came in, lost his pulse, was open emergency department thoracotomy for blunt trauma. So the you know, as everyone said, the prognosis is dismal, and you know, it just sort of unfortunate, but you did everything. A little unsatisfying not having a lot of not being able to understand exactly some of the issues he had, why he got septic, and exactly where the bleeding was from. But anyway, interesting case, learned a lot.
Thank you very much, sir. Can we go to Portland, Dr. Kasim, your final comments, please?
Well, that's why the pundits say in blunt trauma, cardiac arrest, the prognosis is so dismal, they recommend not to do anything at all. But when you are faced with a situation like this, when the chips are down, you know, you as a surgeon, you have to do your best. And I commend Dr. Lieberman and his team to do the very best they have done for this patient. But, you know, his TBI is so severe. You expect things not to go well. But all in all, heroic measures were applied to this patient to give him a fighting chance of survival. So I must congratulate the team and Dr. Lieberman. I take my hat off to you. Thank you.
Thank you, Dr. Kasim. Trinidad, Dr. Ali, your final comments.
Nothing to add. Nothing to add.
Okay, very good. Thank you. Colonel O'Connell in Vegas, your final comments, sir.
Yeah, great job by the team. I don't think they did anything wrong. Just some very tough calls. You know, 6 of one, half a dozen of the other. Very hard to make some of those decisions. I would say, I wonder, I've got a question for the presenters, like, is this patient arrest because they were intubated? That's something you have to watch for, and patients who are very unstable, they get their medications for induction, they get positive pressure ventilation with decreased venous return, and they can suddenly arrest if they are very questionable. So that's one question, if that was why they arrested. And then lastly, like just kind of on the long-term management, like if the patient didn't have the patient had a non-survivable brain injury or poor prognosis, and the patient's a quadriplegic, and but it sounds like you tried to salvage a leg, and they were trying to get his pelvis back together, and then, but if the patient's, it looks like they're not going to have a functional recovery, do you talk earlier with the family and discuss whether, any of these interventions are going to actually do anything for the patient? That's all I got.
Thank you, sir. Were those questions for Dr. Eidelson?
Yeah, anybody.
Okay. Anyone want to respond to that?
Yeah, I can answer them. First of all, thank you to everyone on this call today for your comments and input. Really appreciate it. And also thanks to everyone at Ryder who really helped take care of this patient. So, it was documented when he got into the trauma bay that he had, a pulse. To be honest with you, I don't think he ever had vital signs. I think when they moved him from the stretcher into the trauma bay, he looked like he was dead. We quickly said, he has no vital signs, intubated him, ED thoracotomy. It all happened really fast. So I really doubt that he actually had any, life-sustaining vital signs when he got to us. He looked pretty dead. In terms of family discussions, we try to keep them updated as best as we can. Unfortunately, we never really knew at what point this would be, quote unquote, maybe futile. We were always optimistic that he could potentially improve. You know how neurosurgery is. They'll never commit one way or the other unless it's grossly obvious that it's like a non-survivable brain injury. So with what information we had, we kind of just kept them going and said, we're going to try this, we're going to try this, we're going to try that. Long story short is, based on everything that happened, the family came in over the weekend to say their goodbyes. We thought maybe he would be an organ donor candidate, but the family declined that, and they elected just a withdrawal of care. And at some point today, we're going to withdraw care, and he'll be transferred to palliative care if he survives the first 4 hours. So that's sort of the end of this story. Unfortunately, despite our best efforts, we just weren't successful on this one.
Thank you, Dr. Lieberman. Dr. Calais, your final comments, please.
Yes, I have to congratulate the case. A very interesting case because very difficult management of the patients like the start and until moment. I believe it's very, very difficult to treat. You can show us some points of the trauma injuries that can be very important. You can show of the thoracotomy in the blunt trauma is possible. Sometimes you have good results, the patients recover. You can make the treatment of this. You can show us the treatment of the rectal injury. What the treatment of this in this case is very important to do. And the complications that you have for hemorrhage have as at the end of the case, and how to treat and how to management it. It's very, very, very nice case to present it. Thank you to share us this case and your experience. Thank you.
Thank you, Dr. Calais. Atlanta, Dr. Frisbee, your final comments, please.
Well, good case. Very good. Sometimes you do everything right. Everything you know how to do is not enough. But hey, that's not our function. We're just to do. And I think you did a great job. The outcome wasn't what you wanted, but most outcomes are never ideal. But in this case, you took somebody who obviously, from all intents and purposes, was gone, brought him back, at least for the time being. And, I think you should congratulate yourself. Very nicely done. Very good case. Thank you.
Thank you, Dr. Frisbee. Boston, Dr. Hoyman, final comments, sir?
No, I have not too much more to add. Yes, we all have been in this situation that we hope against hope that this case will be different, and we try our best, and sometimes we succeed and many times we fail. But it was a very interesting case, very well handled, and my congratulations to the presenters.
Thank you, sir. Dr. Untrack, did you have an opportunity to make a final comment?
Yeah, I did, but maybe just to add something, I think, given what happened to this poor young man, he stepped out of his car, was hit at high speed, brought in, arrived dead in the emergency room. had everything worked and you had a successful outcome, that would just be beyond miraculous. And then also, I think, it's been 3 weeks that you've been working day and night to try and save this poor man. It probably has brought a lot of comfort to his family, knowing that you did that you did everything, you didn't give up on him, you gave him the benefit of the doubt. So I think that has a lot of value right there. And then also, of course, it'll help the next unfortunate person that comes in with this kind of severe trauma. So, I think that, you gave it the good old college try, and I think you did a lot of good, notwithstanding the outcome.
Thank you, Dr. Untrat. Any final comments before we turn to Dr. Marttos to close the session? Okay, Dr. Marttos.
Yes, I'd like to say thank you, Dr. Lieberman, especially Dr. Sarah Eidelson for the great presentation. Sarah, I know that you are busy today, you made it happen. So this shows that sometimes, despite everything you do, the patient don't have the prognosis that you want, but you should always try. And like was mentioned here before, sometimes do everything for one patient, you are not successful, but it's going to help the next patient. I'd like to say that we all try to do our best, and you can see the amount of resource involved in this case, and was just a great discussion here. Thank you all. Good to see you all. Bye-bye.